Please start your session, sir. Over to you.
Thank you. Hello, good evening, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. This webinar, doctors, is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in our portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is amongst the largest manufacturers of ARV, APIs and FDFs in the world and has Asia's largest API manufacturing facility at ACZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered to the patient Oseltamivir, Favipiravir, and Remdesivir, for which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, role of Oseltamivir in flu management, we have got Dr. Pallab Chatterjee and Dr. Subhashish Roy with us. Welcome, Dr. Pallab, and welcome, Dr. Subhashish. Dr. Pallab Chatterjee, sir, is MBBS, DCH, MD in Pediatrics, DNP and FIP, Diploma in Pediatric Sleep Medicine, Colorado University, European Diplomate of Pediatric Respiratory Medicine, Chairperson, Computer and Medical Informatics Chapter of IIP 2021-23, Secretary of West Bengal Academy of Pediatrics 2018-19, Member of Advisory Committee of Vaccination and Immunization Practices of IIP, Member of Executive Committee of IIP in 2020, Scientific Chairperson of West Bengal Chapter of Pediatric Pulmonology and one of the founder members of National Respiratory Chapter of Pediatric Pulmonology. Sir has authored chapters in various textbooks like PG Textbook of Pediatrics, UG Textbook of Pediatrics, IIP Textbook of Pediatrics, IIP Textbook of Tropical Pediatrics, IIP NRC Textbook of Pediatric Pulmonology, Standard Treatment Guidelines, and IIP Book on Immunization 2018-19, etc. Welcome, Dr. Pallab Chatterjee. So welcome. Dr. Subhashish Roy, sir, is MD DCH, Consultant Pediatrician, Manipal Hospital, Calcutta. Sir has 35 years of experience and is Organizing Secretary for SPCON 2023, Honorary Secretary, West Bengal Chapter of Pediatric Pulmonology 2018 to 2024, Joint Secretary, West Bengal Academy of Pediatrics 2022, Joint Organizing Secretary, RESPICON 2007, Joint National Convener, ATM Revision Committee 2021, National Trainer of ATM, RTI, GEM, UAD under 5 Vs, ARCTM modules, contributor of ATM 2009, 2011, 2020 and 2021 and CARE module, contributor of pneumonia in children module, pulmonary imaging module by National Respiratory Chapter. Welcome, Dr. Subhashish Roy. Welcome to this webinar. With this brief introduction, I hand over the session to Dr. Pallab Chatterjee. Sir, you can start your, sharing your screen.
Yeah. Am I audible?
Yes, sir.
Thank you, Dr. Prashant, and thank you, Hetero, for organizing this session. And without much delay, I will start sharing the slides for today's session. And today, what we are going to talk about is the empiric use of oseltamivir in flu management. And as you already know, that this session is sponsored by Hetero Healthcare. So, today we are going to talk about the healthcare challenges in monsoon and their diagnosis. We are mainly going to focus on influenza and its complications and the clinical evidences of oseltamivir and the guidelines and recommendations for empiric use. Now, before we start, we'll start off with a case. This was a young child, 4-month-old male, presented with cough and cold for 4 days, high grade fever, difficulty in breathing, and the attendant has severe cold and cough before this. So, on examination, the child was a sick looking child, had clear nasal discharge, a harsh cough, throat was congested, there was tachypnea, recessions, conducted sounds, fine rales and bronchi, and other systems were within normal limits. So, I would ask Dr. Roy, what are your thoughts and what do you think is the diagnosis in this child and why, what investigations we should be doing at all?
So, good evening. Thank you, Hetero, and thanks, Pallab. Now, this child is having a tachypnea, the child is having recession, the child is having hepatomegaly, the child is sick, very unwell, and definitely there are a lot of respiratory signs and symptoms. Now, the child is 4 months old. At the 4 months, the child is having bronchial crepitations, respiratory distress, runny nose, cough, hepatomegaly. The most likely diagnosis will be bronchiolitis. And as this is the most likely the first episode in a child, and as the child is having fever, coryza, and there are crepitations, because in bronchiolitis we may get more crepitations than bronchi. So definitely I will consider this case as a bronchiolitis. The child is suffering from bronchiolitis. The only thing is that the child is having a contact with a family member or ayah, and so respiratory syncytial virus typically infects the children below 2 years, uh, relatively uncommon in adults. So we will have to think of viruses which apart from RSV in this case also.
Yeah, so basically, we won't go into all these details, but we have this when we have a child with bronchiolitis, we grade them as mild, moderate, and severe. But the management is simple. It's not simple, but there's nothing much that you can do about it. Only give oxygen, and maybe nowadays we are giving a lot of high flow nasal oxygen, and that is helping. But it can become very severe. So this child was thought to be bronchiolitis and started treating. And we also get all these lot of upper respiratory infections in children. They come very frequently, and most of them we don't have to do anything. They will go back on their own by around 7 to 10 days, and some of them can last longer if you are predisposed. Now, this child we did do investigations, was admitted because this child had some problems. And Shubhashish, I will ask you to go through this investigation. We did an X-ray. Now, number one, why was an X-ray required in this child at all with a child with bronchiolitis? And what do we see in this film?
Most,
Because we all know that you are an expert in radiology, in
most of the
chest
bronchiolitis
radiology in children. Hmm.
Most of the bronchiolitis cases, we do not do any investigation. We treat by symptoms, and symptomatic treatment is good enough for the children who are in the mild category. Now, if the child is having very serious respiratory distress, the child is irritable, there is hypoxia, the child is unable to feed, then we may require to admit the child in hospital and give antivirals or antibiotics if there is a concomitant bacterial infection. Then we require the X-ray and all the blood tests, because they do not contribute much to the treatment until and unless the child is admitted.
Yes,
So,
so that was, yeah, the reason. Yeah. Yes,
and
yes.
the thing is that this X-ray is not contributing anything in the diagnosis, and this is more an expiratory film, and that's why the heart is looking bigger. There is a big thymus also, and the lung fields are more or less clear. They here and there few interstitial streaking are there, but nothing much in this X-ray.
Right. So this is what we usually get in bronchiolitis. So that is the reason why we do not do investigations and X-rays and all that, because it doesn't really help. It's a typical viral sort of a picture. But this child was worsening. So over a period of time, this child had a worsening of X-ray, radiological signs, and the child was also becoming more and more sick. So, Shubhashista, can you
Yeah, if you
in
now
these?
see from the progress of the disease, it is very classically depicted in the X-rays. In the first X-ray, there is only air trapping. And to some extent, the ribs are horizontal, the diaphragm is flat. As you progress to the second, the lung fields are more black. The ribs are horizontal, the diaphragms are flat. Now, from the fourth X-ray and the X-ray today, It's typical of viral pneumonia. It is bilateral, interstitial shadow, some alveolar opacities, and their ribs are completely horizontal, diaphragms are flat, so more and more air trapping. And as it is viral, and in the right upper lobe, there are alveolar opacities as well. And in the left side, some alveolar, some interstitial shadows are there. So this is typical of a viral pneumonia. Or in cases of advanced bronchiolitis, we may get this sort of picture.
Yes, so this made us do the testing for this child, and we got influenza A that was positive. And Shubhachis, can you say why, what investigations we should do if we really want to diagnose flu?
No, definitely when the child is having severe distress, the child requiring oxygen, the child is admitted in the hospital, this sort of X-ray picture, we should definitely go for a PCR. Nasopharyngeal aspirate PCR. This can clinch the diagnosis. That will reduce the stay of hospital stay, because if you start oseltamivir, it will reduce the unnecessary antibiotic therapy also. And if you can administer oseltamivir as fast as possible, then the result and the outcomes will be better. And definitely cross infection from the child to the mother will be also, the chance will be minimized. So that is very important here. The doing PCR in this child.
One thing is there. This is a the from our old Park and Park textbook, which had said that this flu is a notifiable disease actually, but we do not notify it. And I tried to
Yes.
notify it once, but to no avail, because the health authorities said you don't have to bother. But it can be a very, very severe disease. So now, having said that, like in the monsoon, we have this sort of an ILI, the influenza-like illness, the H1N1, which was the swine flu that we are all knew, the severe acute respiratory illnesses, and the COVID-19. And this was the Indian data which showed that there is a consistent number of cases and also number of deaths due to the influenza. And this is from our Purple Book 2022. And influenza is has got an alarming incidence and deaths, and it is actually increasing. Now, Shubhasita, do you say about the various types of influenza viruses that we have?
Basically, we are concerned only with influenza A and B. C is very mild and C doesn't pose any problem. Majority are influenza A that we encounter in our clinical practice. But influenza B can be very serious, and many of the cases require hospitalization. So by and large, it is influenza A and also influenza B. C is not very important, and there are basically two markers of influenza A. One is neuraminidase and hemagglutinin H and N. I think you will elaborate on this side. We'll
Yes,
not
yes, yes.
go into that in this slide. Yes, please.
Yeah, so actually this year we were getting a lot of sick influenza B patients.
Right.
So, and they were becoming very, very sick. So if it's influenza B, we have to be very careful. And transmission of flu, it can spread quite far. So even up to 6 feet away, if somebody can is coughing, sneezing, talking loudly, the droplet infection can happen, and the R naught is quite high. So it has to be like stressed that if your child has got a flu-like symptom or a viral infection, it's better to stay at home, not go to school to spread to other children. And also parents, if they have such symptoms, that they should be very careful. But this is the problem, that it starts spreading one day before the symptoms develop. So that is a big issue. So before a person actually knows that they are sick, they've started spreading the infection. So that is very important. So, symptomatically, how do you differentiate, Shubhasista, between these various ILI, the H1N1 SARI? So, it's not always easy to differentiate
Yes,
between
it is.
these.
It is extremely difficult. It is extremely difficult. And respiratory distress is less common in ILI. But one thing I do not agree with this slide is that diarrhea can be there in influenza
Exactly.
infection. It can be there.
Exactly.
So that can be there. And another virus which can present like all these four viral illnesses is adenovirus. There can be fever, there can be myalgia, there can be diarrhea, there can be breathlessness, there can be requirement of hospitalization. All these things can be there. And
Absolutely.
sorry, yes,
पहले बिल्कुल नहीं खा रहा था, अभी थोड़ा खा रहा है, पर वो vomiting हो रहा है.
वही दवा चले
can you please mute your mic?
Yeah, mute. Yes, yes.
खाने एकदम नहीं खा पा रहा है. बैठ लो यहाँ.
Dr. Sanjeev, can you please mute your mic?
Please.
Yes, sure, sir. Yes, yes.
So all it is really very difficult. So that is the importance of the PCR. So if you are having the similar kind of infection, if the child is extremely sick, if the child is being hospitalized, then doing the PCR in COVID time, we used to do PCR even those children who are in a home or in OPD. But here, doing PCR in every child with upper respiratory tract infection is quite expensive and it is not feasible also. So, selection of the patient is very important, and we may require only on the clinical ground. It is very difficult to identify. Only loss of smell, if it is there, then definitely COVID-19 should be thought of.
Yes, and the other thing also about adenovirus, what we have seen is the CRPs are usually quite high.
CRP
So
high.
it masquerades with a bacterial
Yes,
infection actually.
yes, CRP high, and there can be leukocytosis because
Yes,
adenovirus secretes a lot of IL-6.
yes,
IL-6 triggers all this infective pathway, not the allergic, the infective
correct.
pathway. That's why CRP and total count may be higher.
Very high. Okay, and we have these emergency warning signs of flu. So, particularly in children, if these children are very sick, they are unable to eat, they have difficulty in breathing, and they are dehydrated. So, not drinking enough fluids, and so irritable that the child even doesn't want to be held. And these are things that we have to be very seriously, we have to take into account, and we need to hospitalize these patients definitely. And in adults also, you have this, if their like mentation is hampered, they are confused, they have dizziness, and definitely severe distress and worsening and shortness of breath. And these are the complications. So we can see that the complications can range from simple cough, bronchitis, pneumonia, ARDS, and it can even lead to death. So, Shubhash, is now about treatment of influenza. That is why we are here today. So, what do we do about treatment of influenza?
Largely, what the slide says, the majority of the children do not require anything except the supportive management, bed rest, antibiotic, higher fluid consumption, and definitely rest. What you have already emphasized that sending these children to the school increases the severity as well as spreads the disease in the community. So parents should be very careful not to send a sick child to the school. And sometimes, yes, we do require non-steroidal anti-inflammatory drugs, especially in first 2 days when the viral load is higher. The fever is very stubborn. It may not be subsiding with paracetamol. Parents become very anxious. But must be slightly more cautious in the rainy season when the dengue also rampant in the community. And most patients with influenza recover in 3 days, but it is in our clinical experience the illness continues for more than 3 days. Usually
Yes,
a
yes.
week, the child requires 1 week
7 days,
to recover.
yes, yes,
7 days, because the myalgia, the weakness, they persist for at least 6 to 7 days. And if it is very mild, you do not require oseltamivir. But if the child is reasonably sick, then even empirically you can, if there is a clustering of cases in the family, there are many other family members are suffering, you may think about starting oseltamivir.
Yes, and This is about the two types of medicines that we have. Subhasista, can you elaborate on this, please?
Now, adamantans we do not
We use
use very commonly. We are more concerned with oseltamivir. Zanamivir, I have never used. It is usually, I think it is an inhalation drug which is
inhaled therapy.
licensed above 7 years. And oseltamivir gives a fantastic relief to the children who are suffering from influenza virus. In fact, it is almost magical. If you
Yes,
hit the target rightly, even overnight, the parents come and say, Doctor, the fever is less, the child is much better, accepting feed, the cough is also less. Because in influenza,
absolutely.
cough is very distressing. And whatever you give, the child doesn't get any relief. So we use oseltamivir, and we use oseltamivir either after getting the PCR report or in some cases empirically.
Yes. So Zanamivir, actually, it can worsen the asthma. So
Yes,
that is why it is also
it is a
a
very
risky drug to be used
yes,
in these cases. Yes. And oseltamivir is a wonder drug actually.
yes,
So it is basically a pro-drug which is converted to the active form in
right.
the liver, and it is active against both influenza A as well as influenza B. And all the strains are we are getting a few cases of resistance to oseltamivir now, but it's still far and few in between. So it is still a wonder drug, and it really works well.
The
And
oseltamivir, the neuraminidase drug resistance is pretty low.
very
And
low,
it,
very low.
it happens more in those children who are immunocompromised, who are
Immunocompromised.
suffering for a prolonged period of influenza without any symptom. In those children, if you start giving oseltamivir, the drug may, the virus may become resistant to oseltamivir.
And it's got a very simple mode of action.
Yes,
So what it
yes.
does is it just blocks the neuraminidase, and so therefore this virons, no, they actually they cleave the sialic acid bond, and that is why this virions are released into the airways, and it goes on multiplying like that. And if it is not released, then the virus comes and it sticks, and then it is not released anymore, it's stuck there. So, and that is how it stops the spread of this virus. So it's quite a novel method of action, and it's approved in more than 100 countries. So the dosage, Shubhasista, how do we actually decide the doses of oseltamivir?
Basically, two things. One thing for the practitioner, we must keep in our mind that oseltamivir is not an antiviral drug. It doesn't kill the virus. It stops
Yes,
only the transmission. And
transmission.
this is number one. And another good thing is that couple of years back, the parents were extremely distressed while procuring oseltamivir. They have to submit the xerox of the prescription, and it was not available in most of the counters. But thank God, now it is widely available. Now, basically, the prescription you can give milligram per kg of body weight, but it is basically given in the weight band. So less than 15 per ml, it contains 12 milligram. The syrup I am talking about, the syrup is 12 milligram per ml, and the capsule is obviously 75. So less than 1 year, if you are giving, it is 3 milligram per kg of body weight. If the child is 3 to 6 months, 6 months to 11 months, it is 3.5 milligram per kg of body weight. Rest after 1 year, it is basically on the weight band, that is 2.5 ml, 3.5 ml, then 4 ml, then 5 ml. Like this, we in two divided doses, we prescribe the oseltamivir, and in prophylaxis, it is not twice; it is once. So half
But
the dose.
nowadays, actually, we don't give the prophylaxis, no? Actually, it was used during the COVID period, during the swine flu period. But
Swine
after
flu
that,
period.
yes, yes,
If the child is having immunocompromised, chronic liver
immunocompromised.
disease, chronic kidney disease, diabetes mellitus, there you need the prophylaxis. Otherwise, a well child, healthy child, immunocompetent child, the role of prophylaxis is much less.
Yeah, and as Dr. Roy was saying that there are studies where they say that there is an empiric use of oseltamivir is now recommended. So oseltamivir treatment for influenza illness, it reduces the lower respiratory tract infections, the diseases, and the antibiotic use and hospitalization. So this was data that was on 3,564 subjects and a wide age range from 13 to 97 years. And what was done was the retrospective chart of these patients were reviewed and conducted. And was found that the subjects were divided into four groups based on the time when the oseltamivir administration was started. And what was found that the earlier oseltamivir was started, the response was much better. So that is why it is always suggested that you start the medication at the earliest. So it progression to severe pneumonia comes down if it's given early. However, if there is a sick child and it you start it even after 48 hours of infection, it still works. So that is why even in a sick child where it's the child is hospitalized and the child is having problems for a few days, we should not shy away from using oseltamivir because we have missed the early opportunity. So that is important. So the WHO says that empiric treatment is recommended. It should be started as early as possible. And not always do we need lab confirmation of the viral infection because if there is an epidemic that is going on, then it's required. And also, uh, we have seen many cases where we have done the test, the PCR test has come negative. However, after repeating after 1 or 2 days, it's come positive. So it is even a negative result does not rule out infection with flu virus. And high risk individuals, Dr. Roy has just now said that we have to treat when they are sick or even during giving them prophylaxis. And early empiric therapy is supported, and this is again by the guidelines of issued by the Government of India, Ministry of Health and Family Welfare, that we have to give a drug like oseltamivir when there is a travel history or there is an exposure to influenza. And again, this is a recommendation which says that all adults with community acquired pneumonia who test positive for influenza. So whenever is so irrespective of the duration of illness, that is very important. So if you have missed the early opportunity, it does not mean that you do not treat. So you start treating even though you know that starting the treatment in the first 48 hours gives the best result. So that is important. So we have to be on the lookout. Sick child, or if there's an immunocompromised child, start treating early. So, Shubhashita, this is an older child, a 2-year-old, fever for 3 days with chills, dry cough, gradually increasing with time, sore throat, and the congested conjunctiva. The child has got vomiting, body aches, and this was the respiratory rate with a harsh vesicular breath sound. And the child was started on comoxiclav and cough syrups. There was no improvement. So, what would you do, Shubhashita, with this child?
So this is a 3-year-old child, quite sick and dry cough. There is a sore throat, conjunctiva, body ache, vomiting. Um, and the father was admitted with a high fever, fatigue, severe cough, and today tested positive for influenza B. Now, as there is a very strong history of contact with an influenza patient, I will definitely not wait and start oseltamivir without getting confirmation from PCR. Now, there are three terms: a suspected case, a probable case, and confirmed case. This is basically a WHO criteria. Suspected case means this child is a suspected case, where you have a contact with the influenza patient, or when there is a similar type of illness in a community where the epidemic is going on. Probable case means you have identified the influenza virus, but you have been unable to identify the type of the influenza virus, whether it is A or B. So that is a probable case, and confirmed means you have identified and you have classified the influenza virus as well. So in a suspected case, and this child is quite sick, the father has been admitted with influenza B. I will not waste time and start oseltamivir.
Yes. So, can you elaborate on the
So
categories?
there are three categories. There are three categories. Obviously A category is the mildest category. The mild fever, mild cough, mild sore throat. There is not much of body ache, not much of headache, no diarrhea, no vomiting. These children require only supportive management, no oseltamivir. Now, if the child is having these sort of symptom plus the fever is very high and severe sore throat, or category A plus risk factors means the child is having chronic lung disease, kidney disease, or heart disease, diabetes mellitus, or the premature child. These children, you have to start oseltamivir and you have to send a sample for PCR. And the category C is the severest category, where category A plus the child is having breathlessness, chest pain, drowsiness, falling blood pressure. Now, this child is not to be treated at home, must be admitted, and as soon as possible, you start oseltamivir. In fact, I can recollect one of our colleagues who is very well known to you also, Dr. K.K. Ghosh,
Yes.
lost his life not just because oseltamivir was not started in time. So it is very important whenever you have a strong suspicion, even before getting the result, you can start oseltamivir, and we are basically using the neuraminidase inhibitor like oseltamivir, zanamivir, as you have told, that it increases the breathlessness if the child is having concomitant asthma, and other drug we do not use in clinical practice very commonly.
Yes. So, actually, who should take these antiviral drugs? Those who are hospitalized with flu, those who are very sick with flu but need not be hospitalized, those who are at increased risk of serious flu complications based on their age or underlying conditions, as Dr. Roy has elaborated, and like people like, asthma, chronic lung disease, diabetes, heart disease, and also pregnant women. So these are the patients who should take the antiviral drug even on suspicion. So we'll come to another case, a 2.5-year-old child with fever, with chills, body ache for 2 days, severe cough the next day, sore throat, breathlessness, not taking. So this child has become very sick. So this child was admitted to hospital. The other family members were all okay. So symptomatic treatment was started. Now, Shubhasista, what should be your if this child is still not improving, we've done a
Now,
chest X-ray.
yeah, now this child is showing again a picture of viral infection because there is severe air trapping. You can see the contour of the diaphragm. There are interstitial shadows, the left upper lobe. There are few alveolar shadows, but mostly reticular nodular shadows. Reticular shadows are more. So it is definitely a viral infection. I should send the blood for PCR. And if the child is severely sick, then I will not wait sending the sample. I may start the oseltamivir definitely. Though there is no family history, but the child is quite a sick child and the child is less than 2 years, which is again a high risk period for the influenza.
Yes. So here, this child with the nasopharyngeal swab, influenza B was detected, and this child was started on oseltamivir, and the child had improved. Antibiotics were withdrawn. Now the problem started. After 2 days, again the child had very high fever with chills. The child was tachypneic. There was bronchial breath sound in the infraclavicular region. Now, what do you make of this child now?
So in in influenza infection, if the child is having, if the child is deteriorating, the child is having a chill with fever, and after a brief spell of improvement, the child has deteriorated bronchial breath sound in the infraclavicular region. Definitely, I will think of some bacterial complication. And this is pretty common in influenza virus infection. And I will definitely doing an X-ray and do the specific therapy, start the specific therapy. And in the left-hand side X-ray, there is an upper lobe consolidation. And if you see, the child was admitted, so the child is already admitted, ceftriaxone added. 2 days later, even after the ceftriaxone, the fever is more, the child is toxic, CRP is very high. And in the right hand side X-ray, you can see there is a necrotizing pneumonia, there is a breakdown areas. And the children who suffer from and who are getting admitted for influenza virus, the respiratory epithelium is severely damaged. So there is a significant chance of staph infection in those children who are suffering from influenza. So if the child suddenly deteriorates, we must keep in our mind that it can be a staphylococcal infection.
Yes, so somebody said that influenza, like, you have a doormat and you wipe your feet and the dust falls off whenever you want to brush it off. But then if the doormat is wet and you wipe your feet and the dust sticks, so the bacteria, no, the
Yeah.
virus makes the lungs sticky and the bacteria will come and stick. So this child had actually an MRSA post-influenza, and this child needed
And
a lot of.
surprisingly, post-influenza MRSA is a deadly situation. So it is not only vancomycin is required, it is the lung penetration and the clearance of the bacteria becomes very difficult. That's why you should add with vanco either Clinda and Cloxa also. So
Yes.
this is and of course with Oseltamivir.
Thank you. So to summarize, what we learned today from Subhashista is that proper diagnosis can and early treatment can prevent flu complications. Flu complications can be very serious. So we have seen cases where it's a very young child presenting as like a bronchiolitis. We have seen a classical flu with a classical history, family history, and we have seen children with another case with severe complications where the child had a very difficult and hospital stay. And empiric use is good because it reduces the lower respiratory tract complications. It can help in preventing hospitalization, and it can also prevent in reduce the usage of antibiotics. And as it's a very raw area that Dr. Roy has touched upon. One of our very favorite seniors from whom we've learned a lot of respiratory medicine and pediatrics lost his life because oseltamivir was not started on time. And WHO, ATS, and the Ministry of Health and Family Welfare, they all recommend the empiric use of oseltamivir, so it should be started as soon as possible. Thank you very much. And with this, I will stop sharing, and I think we can take any questions if there are any on the site.
Sir,
Dr.
thank you
Prashant,
so
over to
much.
you.
Sir, thank you so much. It was lovely, insightful, especially the third case where superadded MRSA infection post-COVID was really an interesting case. I mean, I'm sure the audience has benefited out of this interaction. And really sorry to hear, one of our senior colleagues, passed away because of Oseltamivir. We're extremely sorry. But
Yeah, we learned a lot of our pediatric when we were postgraduates, he had just passed out, and we
yeah,
learned a lot of our pediatrics from him. And then we later on, when we came into practice, then he was already doing a lot of respiratory
right.
medicine, and so we learned a lot of our respiratory
Yes.
practice from him. So yeah, so it's very, very sad.
And it shows the importance of using Oseltamivir at right time. That's very
Right,
important.
right,
Yes.
right, right, right.
Thanks, Dr. Subhashis. It was lovely analysis of the investigations. And thanks, Dr. Pallab. Thank you, Nagadevi, and thanks, marketing and sales team of Hitro for a super coordination. Thank you so much, sir. Thanks to time for taking time
Thank
out.
you.
Thanks all the doctor who took
Thank you.
time and attended. Thank you so much. I wish you a very pleasant evening, and you can sign off, sir.
Thank you
Thank
so
you.
much.
Thank you.
And
Thank
thanks, Pallab, for an excellent
Thank you
presentation.
so much.
Thank you.
thank you. Thank you. Thank you. Thank you.
Thanks, Nagadevi.